Hi, everybody. Welcome to today's Student-Led Journal Club Case Reports seminar. My name is Anne-Marie Hayes, and today I will be introducing our speaker, Student Dr. Noah Gordon. Student Dr. Gordon is a third-year medical student at Kansas City University. He earned his Bachelor's of Arts in Psychology at the University of Oklahoma with a minor in Chemistry and Judaic Studies. There, he researched factors that influence the level of trust in patient-physician relationship, as well as post-traumatic stress disorder, PTSD, susceptibility in relation to personality disorders. While at KCU, he has investigated the relationship between hyperlipidemia and sepsis outcomes. Currently, student Dr. Gordon is residing in Fort Myers, Florida, while rotating at Lee Health. He is presently interested in pursuing a career with internal medicine, and in his free time, he enjoys spending time outdoors with his wife and soon-to-be-born daughter. Today, he's going to be presenting about a case study that he observed entitled An Atypical Presentation of Sweet Syndrome. So with that, student doctor, the floor is yours.
Thank you. Okay, so today, I'm going to present a case that I saw in late July while rotating with a hospitalist. It is an atypical case of sweet syndrome, and I think the best way to go about this would be present the case how we saw it in the hospital setting, and then provide some educational objectives and go into a little bit more about the background of the disease. Okay, so let's get started. All right, so a 41-year-old male presented to our emergency department with a diffuse macular rash involving the upper frontal torso and right arm. He said he had had this rash for about 3 weeks, and prior to that rash, he actually had a prodrome of fever, night sweats, and also some weight loss associated because he was having a hard time eating with the rash around his neck. The patient also noticed left nostril tenderness. This was actually prior to what we're seeing in this picture on the right, and I'll show you a picture also of the nodule lesion on his right thumb in the next slide. He identified his occupation as a physician assistant and prescribed himself Valtrax for presumed shingles. Upon failure for that rash to improve, he went to the emergency room, a different emergency room, where they prescribed him prednisone as an outpatient, discharged him to home, and he took a tapering dose for 7 days. On that 6th day of tapering, though, his presentation worsened to what we see today on the right side. So this is the rash he had on his initial visit, which was 3 weeks prior to what we're seeing him today. It was a very nodular lesion. As you can see, there's a sort of central dimpling right in the middle of that rash. And here's some further pictures of the rash. So as you can see, it's predominantly involving his right upper extremity and torso. And you can see also on the left upper side of his arm, it's not in that area, or also extending down into the lower part of his abdomen on the left side. It was definitely worse on presentation in the axillary area, where you can see there's a Band-Aid there in the first picture. That's where they took a skin biopsy upon admission. And it's important to note that this rash is asymmetric. And at this point, although I can't show his face, it was sparing his face at this time. This picture is here to demonstrate the fact that this rash spared the areas of pressure. So when he was laying down, unable to move, the rash did not go to those areas, which we found very interesting as well. And again, the blood you see on the hospital bed, that is from the skin biopsy and not associated with any clinical presentation. All right, so I'm going to start with the history. The only really relevant review of symptoms that ended up being pertinent was the fever that he's been having for the last several weeks. He said he was able to control it with Tylenol. Otherwise, there was no pertinent positives. No flank pain, no chest tightness or chest pain other than the actual pain deriving from the rash, no shortness of breath, and no changes in neurological findings as well. He has a past medical history of ADHD and past surgical history involving a knee arthroscopy, tonsillectomy, and a benign biopsy of a chest wall mass. Mother had diabetes type 2, otherwise negative for no other autoimmune diseases in the family. And the social history, never smoked, drank a little bit on the weekends, no recreational drugs, no risky sexual behavior, and the immunizations were up to date. No reported recent travel history, although because he works as a physician assistant, he did say he often comes into contact with people who have traveled a lot and who are also sick. He was only taking amphetamine, dextroamphetamine for the ADHD, escitalopram, and valacyclovir. And as far as allergies, he's allergic to penicillins with a rash and hives that would result if he were to take that. On admission of the physical exam, he didn't have a temperature. He was at 97.9. Heart rate was 142, respiratory rate 18, and the blood pressure is 126/69. The only important finding that we saw otherwise was this petechial rash you see in the picture on the right around the ankle. And on the next slide, I'll show you a picture with that blown up even larger. Otherwise, respiratory rate, breathing, everything was okay. Bowel sounds was soft and tender in areas that there wasn't the rash. And the skin itself was very warm to the touch, very tender and firm. He was having a hard time even moving around the hospital bed, even the slightest movements left or right, or to take a sip of water. It was in extreme pain. All right, and here are the pictures of the petechial rash. I'll go ahead and blow this up a little bit. You can definitely see this along the ankle, but if we look zoomed in, it does actually extend up further into the lower extremities on both sides, both the right and left side. At this point, our differential was very wide. We thought there was some sort of ludocytoclastic vasculitis occurring with this patient. Our worst fears were along the lines of a hemorrhagic fever or a sort of malignancy such as mycosis fungioides or other malignancy of the skin. In regards to the workup, I'm going to go based upon as close as I can with how the labs came in. With the CBC, it did show an elevated white blood cell count and an anormocytic anemia. And interestingly, considering the petechial rash, the platelet count was normal. So definitely more of a qualitative problem at this point. Then there's also high bandemia at 32%, very high. So some sort of neutrophilic process was happening. In regards to the chemistry, sodium, potassium, calcium were a bit low. AST and ALT were within our normal ranges. He was having hyperbilirubinemia, a direct hyperbilirubinemia, and ferritin and procalcitonin, some inflammatory markers, were very high. In addition, there was also a markedly elevated erythrocyte sedimentation rate and CRP. So in regards to serology, we're going to start with this, and then we'll work our way to infectious disease testing. Again, we had a very wide net, and we so-called open Pandora's box because we were really afraid if this patient decompensated, we had no idea in which direction to head with treatment. So we went ahead and ordered a wide array of testing. So in regards to the pertinent negatives, there was no C-ANCA, no P-ANCA, and the initial ANA screen was negative, although we'll see at the bottom the ANA did come back positive later on with the titer of 1 to 80. Complement, both C3, C4, and the total complement were all low, and the rheumatoid factor and haptoglobin was high. In regards to infectious disease processes, this was definitely a target of ours considering his occupation. He was negative for COVID, monkeypox, group A, and influenzas A and B. Cytomegalovirus was also negative. Epstein-Barr virus, IgM, was negative, and Hep A, B, and C were negative. HIV, varicose zoster, and herpes simplex were also negative. The only relevant findings we had is evidence of a past Epstein-Barr virus infection. So at this point, we decided to begin with empiric treatment. As you can see, we both included antibiotics and steroids, just as a wide approach to see if he would improve. We discontinued the acyclovir that he had originally come in on and treated the low potassium. The patient did in fact respond to these medications, not so much the rash, but when we came in the next day, he was very able to move around. It wasn't so hard for him anymore. And he was able to function and sit up and even eat his food without any trouble. So at this point, we thought the treatment was successful so far. On day 2, we started to get some other results that were relevant. Chest X-ray was normal, and then CT showed the chest wall, a subcutaneous chest wall edema, especially along that right lateral thorax where we saw the rash was the worst, although the collections were not drainable. There was marked skin thickening, and there was a tiny amount of free fluid in the pelvis. And probably what saved the day the most is the pathologist who came in and analyzed that skin biopsy that we had seen earlier. But first, the peripheral smear showed a leukocytosis with neutrophilia with no overt dysplasia. At that point, it had started to rule out potential Sézary syndrome or mycosis fungoides. And then the skin punch biopsy confirmed to us that it was not, in fact, what was our leading differential, which was a leukocytoclastic vasculitis. Rather, the actual infiltrate was comprised of neutrophils almost exclusively. So at this point, we had called the pathologist. It was day 3 or 4 of patient stay, and they told us that given what they're seeing on the biopsy, they had 2 differentials to present to us, and that was either a cellulitis-like infection or sweet syndrome. On day 3, we got some more labs to see how the patient was doing, and although the white blood cell count was decreasing and the bands were decreasing, which was definitely a positive sign, the chemistries were starting to show transaminitis with an AST and ALT that were markedly elevated. We looked into why this could be, and we ultimately decided this was most likely a reaction to the antibiotic. We did follow up with the right upper quadrant ultrasound, which showed increased echogenicity in the liver, which was suspicious for mighty fatty infiltration, but still consistent with what we thought was a drug reaction. At this point, the rest of the care was out of my hands to get access to. We transferred him to an inpatient or a facility with inpatient dermatology. We tried our best to come up with any solutions to either transfer him for an outpatient visit in the local area and bring him back to the hospital, or have a dermatologist that was willing to come into the hospital. But I learned during this time, getting a dermatologist into the hospital, at least in this area, was not going to happen. So we had to transfer him to a facility that had those resources available. So the educational objective: this patient did have sweet syndrome, otherwise known as acute febrile neutrophilic dermatosis. It is described by an abrupt, painful edematous and erythematous papulous plaques or skin nodules, often associated with fever or leukocytosis. Now, this was first described in 1964 by Robert Douglas Sweet, but it often has a female predilection of a ratio of 4:1. The typical age is between 30 and 60, and as I'll describe to you soon here, there are 3 described types that have been seen. The first one, and the most common one, is the classic or idiopathic sweet syndrome. It's associated with an upper respiratory tract infection or GI infection, and it usually develops between 1 to 3 weeks after the infection. It also has been associated with irritable bowel disease or pregnancy. So this is the one we think our patient had. We couldn't find any other associated findings, as we'll see in the next 2 subcategories. Malignancy-associated syndrome is also there. Interestingly, it's most likely to show up in the hematological malignancy, so like acute myelogenous leukemia or myeloproliferative disorders. I went ahead and put in the percentages of the likelihood. So it is important that if you see what you think is sweet syndrome or confirmed sweet syndrome, to make sure to rule out malignancy. Lastly, we have drug-induced sweet syndrome. The most common drug known to cause this sort of sweet syndrome is granulocyte colony stimulating factor. And as we'll see in a couple of slides, drug-induced sweet syndrome and malignancy-associated sweet syndrome actually have a lot of overlap. We think this could even be a potential paraneoplastic syndrome, that cancers could produce the granulocyte stimulating colony factor, which results in the clinical presentation. So here are the drugs that have been associated with drug-induced sweet syndrome. As you can see here, it's a wide array of types of drugs, mechanisms of action. And so there's, at least from what I could see, there's no common trend among these drugs. All right, now let's talk about the pathogenesis. So there's 3 theories out there. some stronger than others in my opinion. First is that there's the belief that this could be a hypersensitivity reaction. The only real evidence to support this is the idea that because the steroids work, what else could this be? So the hypersensitivity reaction, in my opinion, is the weakest, but it's there, and they're, it's just like parachutes. You don't need the evidence to know it works. You just see that it works. Otherwise, there's cytokine dysregulation. This is the one that can be connecting the drug-induced sweet syndrome and malignancy-induced categories there. They did note in some patients that people with active sweet syndrome had higher endogenous granulocyte colony stimulating factor. And so the idea is that perhaps these tumor cells are producing the GCSF, causing this presentation. Lastly, there's some ideas that there's genetic susceptibility to sweet syndrome. There's 3 findings that have been associated. First, the chromosomal abnormality in the 3q chromosome has been also associated. Also, well reported is HLA-B54 has been linked, especially in Japanese patients, and having sweet syndrome. And lastly, familial Mediterranean fever has also been reported in association with the MSFD gene mutation with sweet syndrome. On the following slides, I'm going to go ahead and show you what a classic presentation might look like. So as we can see, these rashes are very different from what we saw in my pictures earlier. You can sort of see a concentric halo and erythema surrounding this, and plenty of space between each of the lesions. Here are some more pictures. I believe this kid on the right here had acute myelogenous leukemia with also sweet syndrome, and you can see the rashes are also just like in the prior pictures with that halo, erythematous marking, and you can even see a little bit in this picture how it's raised off of the skin. And here we have a more atypical presentation. This is more in line with what we thought we were having in our patient. So in this picture, you can see there's a 70-year-old female in this picture who had sweet syndrome, where it's more of a confluent coalesced rash that's involving the upper extremity, and in this case also the lower extremity. So important indicators or things to watch out for in what you're suspecting could be sweet syndrome, that it often mimics cellulitis. And even in the differential from the pathologist, we thought cellulitis was a possibility, although without the response to antibiotics, even broad spectrum antibiotics, it definitely was lower on our list. Also, the leukocytosis and neutrophilia is a main clinical manifestation, and the rash is most commonly asymmetrical, as we also saw in our patient. Interestingly, just like in this patient, it can present in a large cellulitis-like plaque. So how would you proceed in a case like this? It really comes down to getting the biopsy as early as possible. In our patient, it took about 3 to 4 days, even with requesting the biopsy as quick as possible, that we weren't able to get it very quickly and have a definitive diagnosis. So getting that as early as possible into treatment if you're suspecting it is really important. Second of all, systemic corticosteroids is also really important for treating this. It's the only therapy that's known to actually reduce the amount of the rash and the swelling and get them back to feeling normal. The recommended dose is 0.5 to 1 milligrams per kilogram per day initially, followed by a tapering dose to prevent recurrence. Now, although he had a very similar treatment on his initial emergency department visit, we just don't think the steroids were high enough and sustained long enough to actually cause a resolution of the symptoms. So it went ahead and spread. Clinical improvement is expected in a couple weeks. However, it's important to note that you can also get an infection superimposed upon this. So it can be important to direct antibiotics towards the Staphylococcal species. And we can go ahead and take a moment to look into this picture here for we to see what an example biopsy would look like when a pathologist is doing the skin biopsy. And although I can't zoom in too much further, this bottom area where it's labeled the diffuse neutrophilic infiltrate, that is a characteristic finding in both cellulitis and sweet syndrome, as well as the papillary dermal edema, as you can see, flowing up and down these ridges. That's all the edema that we saw in the CT that we weren't able to actually collect, but raising the skin an elevated position, as well as the spongiosis. So here are my references. I also have references scattered throughout the notes if anyone's interested, and I'm open to take any questions.
Awesome. Thank you so much, student Dr. Gordon. That was a great presentation. You did a great job explaining, and I really enjoyed your use of all your visuals, helping like navigate the story. So as he said, if anybody has any questions, feel free to raise your hand on Zoom or type it in the chat if maybe you can't unmute. Dr. Johnston, I think I saw your hand up.
Yes, ma'am. Noah, outstanding case and well presented. This is a very unusual case. And I say that based upon the likelihood of seeing another one like that is far in between. I've got some questions that I'd like to ask you, and part of this I didn't quite pick up on all the history as you went through it, but you had implied 41 years of age and fairly benign history up until this started. The likelihood of a paraneoplastic syndrome coming around and after this is resolving is still something I think you really have to keep in the back of your head, because he had, whether it's, and I don't know if you had the opportunity to follow him at all in far as continuity of care. Do you know his outcome?
I don't know the outcome after the transfer, but he was doing much better on treatment before we transferred him. We were just worried if he decompensated that we didn't have the resources to adequately treat that.
Well, I understand. Yeah. So what I'm thinking is that the critical continuity of ongoing care and outcome, because what had developed, it's kind of unexplained, is the transaminasemia, the fact that the enzymes were trending upward, the pelvic fluid, little, that's a differential that needs to be pursued. And I think the thing that really kind of gets me is the asymmetry of the rash, or at least the examples that you had showed, I should say, of just maybe just one leg or one arm, etc. It's difficult to swallow the fact that it's a systemic disorder. But regardless, you could easily say cellulitis is involved in either of them. But my next question is that if you went and you did a biopsy, was electron microscopy implemented? Did you have any immuno studies to support any abnormal deposits that were immunofluorescent and lit up?
No, we didn't have those resources at the hospital. But yeah, the rash itself was asymmetric all the way through the course. The only thing that was symmetric was the petechial rash. And that's what concerned us most. When we were in a room with probably, I'm saying anywhere between 10 and 15 physicians. And this was very well talked about. All the minds were brought together and everyone was just concerned because the petechial rash and the setting of everything else going on was really concerning. And I would also agree with what you're saying about following up for malignancy.
Yeah,
I don't think he's out of the woods yet.
I agree.
It's, the two largest theories is this some sort of immune reaction or is this some sort of malignancy induced reaction?
Right.
Considering he wasn't on any reported drug, at least thus far, that would cause this. So yeah, I agree. And I would like to have some follow-up, but I don't at this time.
Well, I understand. One thing that kind of caught my attention when you cited vital signs, his heart rate was really out of proportion to the amount of fever. As I recall, I don't know how high his temperature was, but you had mentioned fever. The heart rate of 142 is pretty fast. I don't know, maybe it was pain, a combination of pain and some of those things that could easily add up. So I missed his occupation. What did he do?
He was a physician assistant working in an urgent care.
I see. Okay, I missed that. And then when you cited the quantity of platelets, they're normal, but the quality of platelet function remained kind of still unanswered. And you have to consider that into your differential, because when you refer to petechiae, first thing you think about is there's a platelet problem someplace. And so it could have been, like you said, a qualitative dysfunction rather than a quantitative issue. But overall, my gosh, a perineoplastic syndrome has to be considered in your differential long range wise, and continuity of the question in my mind would be, how long would you keep this guy on steroids?
Yeah, and that's exactly why we wanted the dermatologist on the case. And it was unfortunately a logistical problem at the hospital, but yeah, he was already on that tapering dose to start with when he had his first visit, and that just wasn't enough.
No.
It did resolve the initial thumb lesion that I showed at the beginning, but it spread so more diffusely and it was so painful. And I do think that's what attributed to the heart rate. He was in so much pain that any movement.
And I could buy that. Yeah, I could buy that. Well, you just did a nice job, and I hope you can talk to the dermatologist and see his clinical course, and the outcome of this guy will be interesting. So I compliment you on your presentation and your homework. You did a nice job.
Thank you very much.
Any other questions, comments? If not, thank you so much again, Student Dr. Gordon. That was a great presentation. Thank you, everybody, for joining us on this Friday, and have a happy Labor Day weekend, everybody.
Bye, everybody.
Thank you.